Doc Talk with Dr. Paul Conley is copyright 2021, Signer Foundation, and is solely responsible for the content. And now, Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Hello, I'm Dr. Paul Conley, and thanks for tuning in to another episode of Doc Talk. Tonight we're going to talk about GERD, gastroesophageal reflux disorder or disease. So GERD is actually something that's fairly common in the United States of America. In fact, it's been reported between 10 to 20% of Americans will have some form of reflux. Tonight our guest and our expert is Dr. Scott Killmer. Dr. Killmer is a general surgeon here at Plateau Medical Center. Dr. Killmer actually treats and diagnoses the disorder of GERD, and he also himself has had symptoms of GERD. And so tonight, Dr. Killmer is going to walk us through GERD, reflux, and some of the alarm features that are associated with this. But he's also going to undergo an upper endoscopy himself so we can evaluate some of the symptoms that Dr. Killmer himself has been having. So Dr. Killmer, thanks so much for coming on the show.
Thank you.
So, when we think about GERD or reflux, I think, a lot of us think about heartburn, and I think that's kind of classic. People talk about this sensation in their chest. But there's more to it, right, than just heartburn per se. So maybe you can tell us like some of the symptoms that, can present when someone's having acid reflux.
Yes, people will have maybe a burning sensation, the sour taste of the reflux into their mouth. It may present as chest pain, upper abdominal pain, and the thing is that sometimes there are minor issues going on, and sometimes these are the tip of the iceberg, and there could be things as bad as cancer or even large ulcers and scarring at the end of the esophagus and precancerous esophagus. So there's a whole myriad of lesser symptoms and greater things that could be underlying. So it's important to figure it out.
Yeah, I think, when we talk about, I guess maybe you can, let's back up just a second. What exactly, when we talk about GERD or acid reflux, what's happening? What physiologically is going on? I mean, we talk about the esophagus, the swollen tube, and the stomach. The stomach has, gastric acid. So describe what physiologically is giving these symptoms. What's happening?
The mainstay of the problem is the diaphragm. That is the muscle that divides the chest and abdomen. It has a hole in it that lets the esophagus go through, and that hole is the hiatus. And when that hole dilates, we call it a hiatal hernia, and it makes it so loose that the stomach will slide up through that into the chest to some degree or a lot. And it just widens the area and allows the acid to flow backwards.
Yeah, I think, we talk about there is a sphincter at the lower esophagus, so we call it the LES or lower esophageal sphincter, and, many times the diaphragm kind of helps keep that closed, and when the stomach is up in your chest, you no longer have the diaphragm to help, and then you get acid can reflux up, which again, the esophagus was really never intended to handle acid. The lining of the esophagus is different than the lining of the stomach. So people watching this show, they're going to ask, what things can contribute or cause, acid reflux. I know I get a lot of patients who, they smoke or they take anti-inflammatories, caffeine. Or tell me a little bit about like what are some of the things that diet modification or certain medications or things that we do in the community that increases reflux?
Certainly the things you mentioned that stimulate acid in the stomach, alcohol, nicotine, and caffeine are the three dietary issues that are the graders. Overeating and having an overly full stomach is an issue, and particularly eating late at night and having something in your stomach when you lay down, and that's when the reflux is greatest. So we ask people to do reflux precautions, which is the opposite of all of these, to try to minimize alcohol, tobacco, and nicotine, to try to minimize overeating, minimize going to bed with a full stomach. I tell them go to bed with an empty stomach, and pick a time, a number of hours before they go to bed to stop eating. And when people do these things, they tend to also lose weight, and so weight control is huge. For me personally, I recently started in January losing weight, and my acid control has remarkably improved. But I'm still dependent on my acid medicine. If I miss it for one day, I start burning at the end of my esophagus, I presume. And again, that's partly why I'm here, is I need to know what's going on. It's been 4 or 5 years since I had my previous scope, and that's time.
Well, I think that's, one of the things that's important, just like you talked about, was, we know it's not so much body mass index, but it's actually waist circumference. And so when we think about number of inches of the waist, proportionally increases, acid refluxing up. I know I usually ask my patients to at least give themselves at least 3 hours before they go to bed to stop eating. So if you go to bed at 10 o'clock, nothing after 7. I don't know about you, but I'll ask them to even, prop the bed up, 6-8 inches, usually blocks. I discourage using pillows, because when you use pillows, the body ends up in an abnormal bend, and many times that can make the reflux worse. But if you can elevate the bed, so now you have gravity more on your side, so the acid is pulled down, because when we're upright, we have gravity on our side. But I think, some of the other symptoms, that we talk about, I was talking to our ENT earlier today, and he sees a lot of symptoms of GERD that are things such as wheezing or coughing, especially nocturnal cough, or even hoarseness of voice. Some people even complain of this fullness in their throat, called globus. But I think, you brought up a point, if you have chronic reflux and you're talking, for up to 5 years or longer, then you need to be evaluated. So maybe you can just talk to us about some of the things that would alarm you, that you would then want to consider an upper endoscopy. That if someone presented to you, what were some of the things that would be alarming that you would say, you most definitely need a direct visualization, you need an exam of your esophagus?
Certainly there's a handful of, again, greater alarming issues: weight loss, difficulty swallowing, evidence of blood anywhere, spitting up or going through. But again, sometimes some people have just a little bit of acid that they think they're controlling and have never looked, and sometimes something really bad can be lurking down there, up to and including cancer, or big ulcers in people that I didn't expect it, with little symptoms. And certainly figuring out whether they have the bacteria H. pylori in their stomach, which we do when we do endoscopy as well.
Yeah, I think, we think about, precancerous disease, and it's a condition called Barrett's esophagus, and that's one of the things we're going to be looking at today with you, is to visualize if you have Barrett's. And the thing with Barrett's, it is a precancerous condition that no imaging test will pick up. CAT scan, X-ray won't show it, and upper endoscopy we can visualize that. And we do know that Barrett's, again, the risk factors are chronic reflux, acid exposure to the distal esophagus causes that esophagus to lay down this epithelium that has precancerous cells in it. So, as we're going to get ready to do your upper endoscopy, one of the things I think that we do have some medications out there that we use for acid reflux. And I think that, there's been some press about these proton pump inhibitors and potential side effects. I think people have seen the potential side effects of heart disease, chronic kidney disease, dementia, bone loss, and fortunately, there was a large study performed, 18,000 persons were in this study, called the COMPASS trial. And what they found was that these proton pump inhibitors are definitely safe. And so for people that have, Barrett's esophagus or reflux esophagitis, or anyone that's ever had peptic ulcer disease on anti-inflammatories or blood thinners, most definitely would want to continue to be on their medication. The proton pump inhibitors are the mainstay. But there's some people, Dr. Killmer, that I, being a medical doctor, where I place them on a proton pump inhibitor, and let's say they're on the medication twice a day, like omeprazole, let's say, and they still, despite my using twice daily medication before breakfast, before meals, they're elevating the head of their bed, they're cutting out caffeine, they're cutting out nicotine, let's say. And so I've kind of run out with what I can do as a medical doc. Then I refer that patient to you as a surgeon. So what surgical options do we have available for that patient that has refractory, let's say they failed medical treatments?
There are several related general surgical procedures that can be performed to repair a hiatal hernia. The procedure that I do is a robotic assisted laparoscopic repair of that hiatal hernia with a partial wrap of the stomach that repairs the hiatal hernia and fixes the angle of the stomach. By doing a partial wrap, it minimizes people having difficulty swallowing afterwards, and I consider it a very good fix of the hiatal hernia. Generally, to me, hiatal hernia, if you measure them from 1 to 4 centimeters or so, those should be able to be managed almost always. When you start getting to 5 centimeters and up, then their management medically becomes more difficult and their symptoms go up, where I tend to find some of those needing surgery because they can't control the symptoms.
So in your situation, you can not only repair the hiatal hernia, but you can also do this wrap to where it prevents acid from coming up that lower esophageal sphincter we talked about earlier. I know there's been a lot of improvements, with the surgery, especially with robotics, that people recover so much quicker. And definitely there are folks that, despite, basically, maximum medical treatments out there, that still, need to be referred to someone like yourself, who can then perform a surgical procedure that can reduce their acid reflux. Because again, we know that chronic acid exposure, chronic reflux to the esophagus is damaging the esophagus and can go on towards something like Barrett's esophagus and even esophageal cancer. So anyway, we're getting ready to come upon a break, and so Dr. Killmer is going to change his clothes. He's actually going to get into a gown. And when you guys come back, we're going to be in the endoscopy suite where we're going to perform an upper endoscopy.
Doc Talk with Dr. Paul Conley is copyright 2021, Signer Foundation, and is solely responsible for the content.
Endoscopy unit here at Plateau Medical Center. We have Dr. Killmer here, who's been having signs and symptoms of reflux. We have Maria here with us, our nurse anesthetist, who's going to be giving the sedation. And as you can see, the sedation is going to be propofol, which is something that gives the patient adequate sedation while performing the procedure. This is an endoscope. The endoscope has a light source at the end of the scope, which we can visualize the esophagus, the stomach, and also the small bowel. So Brandon's going to give me a little bit of lubrication, so we lube up the distal end of the scope. And what we do is we actually take the scope and we're going to pass the scope in through the mouth. As we pass the scope in through the mouth, what you'll be able to see is we're going to pass right below the vocal cords here. So we just go a little bit distal to the vocal cords here. So as we advance the scope, this is the swallowing tube. This is the esophagus. And the esophagus is approximately 10 inches long and about 1 inch in diameter. Now what you're going to see right here is we see some reflux esophagitis right here. So esophagitis means inflammation of the esophagus. We also see a sliding hiatal hernia. This is a diaphragmatic notch, And so what we're talking about, Dr. Killmer's talking about the diaphragm. This part of the stomach is actually just above the diaphragm, which is what's causing him to have some reflux. This is the pylorus. This is where the stomach itself, which is we're in the stomach now, goes into the small intestine. So we're going to go right in this area here. This is the small bowel. The first portion of the small bowel is called the duodenum. So the duodenum is an area where we can see things like celiac disease, gluten allergy. So Brandy's giving me a cold biopsy forceps. And what we do for gluten sensitivity, we'll get multiple biopsies of the esophagus. Open, close, open again, close. Take that, then hand that back. And we're going to send these specimens off. We're going to be looking for inflammation of the small bowel and atrophy of these villi, these finger-like projections which absorb nutrients. Someone that has a gluten allergy, these villi will be blunted. So we're going to get a couple more bites right here. Open, close, open again, close. So you see our biopsy forceps getting the tissue. And we'll get one more pass, we'll get that in the bulb. As you can see here, I have the scope retroflex, and so we actually have the scope in a J-like maneuver. We can pull the scope up and we can look here at the cardia. This is the upper part of the stomach. And you can see the scope pass as we can look at the rugal folds. These are the folds of the stomach here. So we're going to go right back through the pylorus. This is the bulb. And Brandy is going to get a couple more bites. We can actually get 2 bites per every pass with these type of forceps that we're using today. Open, close, open again, close, open one more time. Get a little better bite. Close. Very good. Okay. So we're going to send that off, and what we're looking for there is if Dr. Killmer were to have, or any patient were to have, any problems with gluten. So again, this is the pylorus. This is what goes into the small intestine, and again, you see it's a little bit red here. It's a little bit inflamed. You can see as I get real close. See these little red little petechiae here? So we're seeing a little bit of inflammation. That's called gastritis. If we see oozing or bleeding of that, that's called hemorrhagic gastritis. So one of the things that can cause that is a bacteria called Helicobacter pylori. It's a bacteria that likes to live around the pylorus, and that's where it gets its name. Open, close, open again, close. So what we're doing here is we're taking biopsy specimens of this area, and we're going to send it off, and the pathologist will be able to evaluate for this bacteria called H. pylori. Other things that can cause inflammation like this would be if he was drinking a lot of caffeinated beverages. Coffee, tea, soda pop can cause inflammation in the esophagus. The other thing that can do it are things like anti-inflammatories, Advil, Motrin, Aleve, ibuprofen. All these things can also cause gastritis. Open, close. Open again, close. So peptic ulcers are things that are attributed with H. pylori. So if one has H. pylori bacteria, we would definitely want to treat that. So you can see these little small pinches that we took off that we're going to be sending off for a biopsy and pathology as well. Okay? So as we kind of start easing up out of the stomach here, we're again looking at the rugal folds. We're looking to make sure there's no evidence of any ulcers. We can visualize to see if there's any tumors or cancer, which we don't see anything like that in the stomach here. Again, these are these rugal folds, which kind of help aid with digestion as the stomach digests and starts to break food down. Again, the stomach's designed to handle gastric acid, but when it gets up in the esophagus, which we're up into here, you can see this, okay? Now, one thing that we have here is we have something called narrowband imaging, and you can see what I did right here. See how we took the white light out? And by taking out the white light, what you see, we call this villiform or mosaic pattern. This right here is abnormal. The Z line should be a nice line. And you can see here, see these little villi form or mosaic? That is not normal. That can be a sign of something called Barrett's esophagus. And so we're going to get some biopsies here of this distal esophagus. Again, Barrett's is from chronic acid reflux. So what we're going to do is we're going to take our biopsy forceps. We're going to come down out of the channel here. And we're going to get some specimens of this distal esophagus. Open, close, open again, close, like that, and we're going to get some more pieces here. So again, we're talking about Barrett's esophagus. We know that Barrett's esophagus is a precancerous condition that is associated with chronic reflux. So an individual that's had reflux symptoms for over 5 years most definitely would want to be considered for an upper endoscopy for evaluation. Other risk factors for Barrett's esophagus are male sex. This tends to be more common in men. Open, close, open again, close. People that smoke, people that are obese, because remember we talked again about how your waist circumference increases the risk. So we're going to get 2 more pieces here. We're going to send off again. We're looking for abnormal cells, and these abnormal cells are a precursor. It's almost kind of like if you have precancerous lesions on your skin from sun exposure. So instead of sun exposure, this is acid exposure that's causing this appearance of the distal esophagus. Open again, close, open one more time, close. Okay, good job, Brandy. So Brandy's going to send it off. Megan's going to put that in our specimen container. So again, Megan, that'll be distal esophagus. So Megan's going to label this as distal esophagus, or actually right at the GE junction, so the pathologist knows exactly where that's at. So we got biopsies of the duodenum. We got biopsies of the antrum, which will be in that second container. And then the last container is going to be here at the end of the esophagus. So again, you see the stomach's kind of coming up here. That is actually his hiatal hernia, which measures almost 5 centimeters, and he's starting to form a Schottky's ring here too, and that's always associated with a hiatal hernia, Schottky's ring, and sometimes people, again, like we're talking about, can have dysphagia symptoms. So we're coming out of the esophagus now. We're working our way out, just looking for any other abnormalities. As we're coming out, there's his vocal cords right there. There. See the vocal cords? And we are done. So that's an upper endoscopy. So one thing we got to see today is we got to see his small intestine, we got to see the stomach, and we got to see a hiatal hernia, a sliding hiatal hernia, and we saw reflux. And again, this is damage from chronic acid reflux. So what we're going to do right now is I'm getting ready to go do an operative report. Dr. Killmer is going to go to recovery, and when we come back after this commercial break, I'm going to go over my findings with Dr. Killmer. So stay tuned, and we'll be right back. Welcome back to Dog Talk. We are now in the recovery unit here at Plateau Medical Center. You just witnessed an upper endoscopy performed on Dr. Killmer. Some of the things that you got to see with the upper endoscopy were things that we talked about. We got to see a hiatal hernia, about a 5 centimeter sliding hiatal hernia. We got to see some reflux. You got to see reflux esophagitis, and we saw some inflammation in Dr. Killmer's stomach as well. So we took multiple biopsies, and we'll have these all sent off. So how do you feel after your scope? You feel okay?
Better.
So, one thing that, you and I talked about, earlier was the fact that, you do have a sliding hiatal hernia and you do have some acid reflux. And so one of the things that we had talked about was talking about medical treatment. So first of all, we're going to try to suppress acid with these proton pump inhibitors, which again have been shown to be safe. And in a situation like this, we would want to continue long term because we don't want to have any additional acid exposure to the esophagus when we saw the findings we saw today. So what we're going to do is we're going to do a high dose proton pump inhibitor. We're going to use Protonics, and we're going to use 40 milligrams twice a day, one before breakfast and then a second one before supper. And this should hopefully help reduce those parietal cells, these acid producing cells in the stomach, from making excess acid. Other things Dr. Killmer we've talked about, he's already on a weight loss regimen, not eating meals before you go to bed, at least a few hours, and trying to cut out caffeinated beverages, coffee, tea, soda pop, and anti-inflammatory. So does that sound pretty good with you?
Yes.
So one of the things that we're going to get the biopsies back, we'll have those for follow-up, and if he does have Barrett's esophagus, then we would talk about Barrett surveillance. And if he continues to have issues with that 5 cm sliding hiatal hernia, we'll talk about surgical intervention. In fact, on one of our next episodes, we're going to even talk about how we can actually repair hernias here at Plateau Medical Center. We actually have a robotics department and a robotics program in which hernias like we got to see today can be repaired robotically, but that'll be in an upcoming episode. So basically, I appreciate you coming in today. Appreciate you allowing us to actually perform your upper endoscopy. We're going to, again, double up your protonics. We'll have the biopsies for your follow-up, and then we'll see you back in clinic. For those of you watching our show, again, you can check us out on WzTs Monday through Friday at 7 p.m. and also on PBS. I'm Dr. Paul Conley. You've been watching another episode of Doc Talk. Until next time, have a good night.